just a reminder that we're audio recording this session. So if you have, when you ask questions, your voice will be audio recorded and our responses will be too. And remember that this isn't the place to ask the ministry policy questions. You can do that at any time with an email into the ministry. Now is a chance just to talk about issues that are coming up, ways that we can help, resources we can point you towards, areas where we might not yet have a resource but need to. So we'll open it up for questions. Because we're audio recording, we have a mic. So if you can put up your hand to ask a question, that would be great. I'll start first checking in to see if our colleagues online have a question. So Morgan, do you mind passing Carrie the mic, and then she'll read out the question from the WebEx line? Should we check to the room? Okay, so questions, comments from folks in the room? Anything that I said surprise you? Anything that you want to particularly hear more about, or you'd like resources about? I mentioned before the thing that comes up the most is attribution. This is going to be a busy 10 days for you whenever your data comes, because you're going to need to quickly respond to that, because the ministry in the full application is looking for well-justified choices of things like priority populations, and wants to see how you have responded to what you've learned about your attributed population. So any questions? Yep. So a question at the back. Yeah, there we go.
I did encourage you to do that.
So just a question around the data sets, and
Sure.
really trying to understand it from a health equity lens.
Yep.
And the fact that the data perpetuates maybe inequities by communities and by components of the system. So how do we actually go a little bit deeper and say, so some of this may actually be component parts that we want to fix. The data is actually suggesting that there's gaps and issues, as opposed to saying, well, that's actually a starting point. So how do we balance that? Because the data is obviously a foundational piece of how we move forward, but how do we do the analysis to suggest that the data may actually be
part of the problem?
Part of the problem.
Yeah, no, I think it's a great point. But I just encourage you to be honest about that in filling out the full application. I think it is. I mean, the data that most of us currently have access to is skewed to certain types of providers and isn't giving us the fulsome take on what's happening. Now, we are seeing some communities through their participation in things like IDS, where they are convincing their primary care colleagues to add primary care data to it. And what they hope is over time, municipal governments, other people will add data to it, which over time will then provide a far more fulsome picture. So what I'd encourage you to do on the full application is be very clear about how you're using the data in some ways, but you might not be using it in others because you don't yet feel it paints a fulsome picture, but that you're very committed to increasing those data assets and drawing more out of them in future so that you can really address the equity piece. So my sense is the ministry is very aware of the strengths, but also the limitations of the data. And so use the data that you feel that you have confidence in, but point out how you will over time with the digital health building block, which includes the data, build on that so that in future years, you'll keep getting better and better and have more and better access to data that you can use to then really use equity as a way into making big improvements. Yeah.
You mentioned IDS, so that's out of Hamilton Health Sciences, and it's for those that are not familiar with it, a very powerful tool that actually drills utilization in particular at the patient level, and actually starts to draw some amazing observations around appropriate but also inappropriate utilization.
Absolutely.
For example, in many cases, use of emergency departments that clearly points to the fact that care could be shifted elsewhere more appropriately. So are you able to provide some access to IDS as well to some of these groups, just to give them samplings of, obviously it'll support the Hamilton population much better, but it is a very
yeah.
revealing tool.
No, so great question. And keep in mind that we have no kind of skin in the game in any provider. So the fact that they happen to be based in Hamilton, it does not lead me to recommend them. But when we were asking around and doing interviews on for the data analytics brief, people initially pointed us to IntelliHealth, but then IntelliHealth, it's like you're pulling in these disconnected data sets. But what IDS does is it links the data across a patient journey. So you can see how the patient saw primary care, they had home and community care, they went into hospital, they bounced around. You can see that longitudinal journey, and any group in the province can choose to join IDS. You have to sign a data sharing agreement and so on. My understanding from having had a conversation with them, we didn't put it in the brief because we do not want to talk about groups' plans in case they don't come about. But what we were told was that the IDF folks are actually planning to generate data cuts for any group that has provided data to them. So that will allow other teams to see the rich set of data that can come about if you choose to participate in IDS. So that's one step that we understand is coming soon. So again, not endorsing particular data platforms, but when we asked around, that was the one that people were the most excited in terms of how we now have to start using data. Thanks. Carrie, did you find the question online? Yep.
Okay, so I have two more procedural questions and one content question.
Yep.
So the procedural questions, the first one is, if we have questions or queries about a topic that is not on the RISE site at this time, how should we stream these? Is there a preferred contact?
Yeah, so the preferred contact for everything is to your relationship manager, your contact at the ministry. So the ministry, through the central program of supports, will take those in, and then if it turns out RISE is the most appropriate group to respond, they'll notify us, and then we will move on that. Right now, there's a couple of groups that have already been kind of visibly identified as part of the central program. That includes us, the Health System Performance Research Network that will help with evaluation, ICES that will help with some aspects of data analytics, but the ministry plans to broaden that tent over time. So the risk in writing to us is that we might not always be the right person to respond. So best thing is into the ministry, and then they will loop us in if we are the most appropriate group to respond.
Second procedure question is, when is the digital health playbook being provided? Will it be posted on the RISE resources site when it is?
Yeah, so we're independent of the ministry, so sometimes you might hear the odd thing before we do. My understanding was it's imminent, my understanding was it was likely to happen this week, but as you know, it's always hard to predict these things. There are many approvals that are needed before things enter the public domain. I do think that when it comes out, it's going to be hugely helpful. As I mentioned before, OHTs are a massive transformation in their own right, but they're also an opportunity for us to really get right key parts of the system that we haven't devoted enough attention to, and digital health is an example. So we can do a ton of stuff with our banks. In a few years, we need to be able to do a ton of stuff in our interaction with the health system electronically. Then in answer to the question about whether it will be on the RISE website, yes, absolutely. Anything that gets posted on the ministry website about OHTs, a link to it gets posted on RISE. So you will always know if there's anything available, you will be able to access it through the RISE website.
The next question, I think this relates to attributed populations questions, but the question is, to what degree does current use reflect current funding, and how can we account for the weighted historic investments?
So, well, if it's about attribution, I guess I don't know that the current funding has a big impact on it. What drives the attributed population is largely people's access of primary care. So if you are rostered to a primary care provider, then you are attributed to that individual. And that on average across all of Ontario, 82% of Ontarians are attributed in that way through rostering. Then there's the next big bucket of 16%, which are attributed based on their use of healthcare services, primary healthcare services. So you're not rostered, but you've tended to go to the same family doc or some other provider, so you're attributed to that provider. And then you're only left with 2%. So really what's driving the attribution model is primary care. All primary care is publicly funded, so it should not be the case that current funding is somehow skewing who is attributed to which population. But there's no question, once you get into understanding subsequent utilization profiles, like if you were to use IDS to understand longitudinal journeys, then you start to encounter all kinds of inequities in terms of funding. So what people are currently accessing in the way of funding might be driven largely by what is subsidized or free, as opposed to what might be the right service for them. But over time, hopefully, we'll come to better understand that stuff, and the teams will be able to say, okay, maybe if we move money from here to here, we'll actually be able to have a much bigger impact on people's care experiences and health outcomes.
And one last question, which I think is a policy question, but we'll give to you just to clarify. Can you clarify whether the Ministry of Health is prepared to accept full applications from merged OHT teams or teams with new members, given your suggestion?
So my understanding is that the ministry is very open to teams evolving over time. I've heard them say multiple times that if you start to realize that there are people missing at the table, we strongly encourage you to invite them in. So when you get the maps, if you were thinking that you're mostly covering this area and then you have a big group of people that are coming to your primary care providers for care, then you might need to bring in other partners. So my understanding is that that's been very clear that the folks are open to that flexibility. Our ministry colleagues will have heard the question, so if if there's a disagreement, then in their Q&A section on the website, they'll be able to post a response there. So back to the room. Any questions for folks in the room that we can help with? Explain, give more detail about, take on board as an area where you'd like to see different types of resources. So we still have lots of time. I mentioned before that we'll eventually turn off the WebEx and just have a quick conversation with the folks that are physically in the room, but the more that we can ask the questions with everybody here, the more beneficial. So we know these were booked with very little notice. It's peak holiday time. It's hard to get folks here, but this is the biggest transformation of our health system I think we've ever seen. And the more people that are well equipped to understand the opportunity and the resources available to help them succeed, the better. One of the great things to me about this model is you're not competing with other people. Everybody wants teams to succeed. If you've been invited to full application, the focus is on how can you be supported to succeed and really get those building blocks in place and move the needles for your priority populations. So any other questions from folks in the room? And what about online? Anything else coming in? Heather, can you think of anything else that I haven't covered fully? Otherwise, we'll just give people one more chance and then we'll bring the session to a close.
I mean, I think just from my own interest in potentially our work in the fall, is there, and you mentioned this earlier in your presentation, but is there pieces in particular that you're really struggling with or would require or need additional information, aside from the attributed population piece that we talked a lot about already? What can we help you with? Whether it's us or another ministry asset.
Any reactions? Folks online, any reactions? Such a quiet group. If we were in a much better room, it would probably be easier to speak. That person was preceded by a little bleep. It was like Aunt Clara arriving in the fireplace.
I can't fix the chat function on there at the moment, so that's how
okay.
you know.
Okay.
So there's two, actually. So
Yeah.
the first one is clarity on home and community care, but I think that is policy. And the second comment is, it's a continuation of that piece, meaning what is the Ministry of Health doing with LHINs?
Yeah, so the second question is absolutely a ministry policy question, so I'd encourage you to direct the question to the folks at the ministry. I'll just tell you how I read the appendix about home care, which is it's your opportunity to imagine what an ideal state would be for your team if there is flexibility in how it intersects with home care. So right now, your team is probably thinking about an area that is much smaller than the area that home care has historically been organized around. So for a number of years, that's been the Lynn region. So what would be ideal for you? If you are now going to start to be accountable for the health of a population, and you want to be able to provide that full scope of services to them, would it make sense that certain functions that are now resident in the Lynn for home care, they were in the Community Care Access Center, they're now in the Lynn, that those actually be within reach of the team, so that the team knows that it's making decisions with the hospital or hospitals around the table, the primary care providers, but it also has home care there, and that those are resources that can be put to use to move the needle for priority populations. So to me, it's again just an unbelievably exciting opportunity to say, wow, if we could redesign home care in a way that really moved the needle for people, what would it look like, and how would we connect it to the team? So it's a piece that my understanding is going to be used by the ministry as it moves forward into decision making about the future state for home care. But it's your chance to articulate what you think would be best for your community in improving care experiences and health outcomes. So final call for the room in person. Anything else? Okay, final call for folks online. All right, so let's bring the webinar to a close. Are we leaving it live for the, no, we were able to shut it off? Fantastic, okay. So thanks very much for those of you who are joining us on live. We'll just continue a brief conversation here in person with the recording turned off, but we're grateful to you for joining us on WebEx, so thank you very much. And don't hesitate to send questions into the ministry contacts, and hopefully we'll see you in person one day. Thanks.